Well, good evening and welcome to the program. I'm Dr. Margaret Fitzgerald, founder of Fitzgerald Health Education Associates. I want to welcome you to the session tonight, our Pharm series for NP faculty. And this one is focusing on pharmacologic options in contraception, a focus on safety and efficacy. Patricia is on with us tonight. If by chance you have some technical questions, and I'm more than happy to take your questions. What I'd like you to do is put the questions into the Q&A box. And if you're wondering where that is on your Zoom settings, if you look at your bar way over to the right, there is 3 dots. And if you click on that, that's where you will find the Q&A box. And with the Q&A box, one of the features of that is no one else will see your name. No one else will see your question, except for me, of course. So as I said, founder of Fitzgerald Health Education Associates. My clinical practice has been in a federally qualified health center doing full spectrum family practice. And I'm also adjunct faculty at Case Western Reserve University, where I did my doctoral studies. I'm on the editorial board of a couple of different journals. And I'm also a member of the Pharmacy and Therapeutics Committee for Mass General Brigham Health Plan, which is a major HMO in Massachusetts. So with that as background, let's get going here. Disclosures: no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented. If I do manage to mention anything off-label, I will make sure I mention that. So what are we going to do? We're going to look at the eligibility criteria for determining patient risk for use of several contraceptive methods, identify effectiveness, adverse effects, and complication of hormonal contraception, and formulate a plan of care for patients with different contraceptive needs and risk factor with, as always, a focus on those teachable moments. This is really the backbone for references for this presentation is the CDC's contraceptive guidance for healthcare providers. You've got the QR code here, so you can download the app that goes with this. This was updated just a couple of years ago after, quite candidly, a long stretch without these recommendations being updated. Now, during the time period that they had not been updated, were there a lot of changes? There was some, but for the most part, added on some contraceptive methods and kind of honed the rough edges over against some of the recommendations. And now this is what we're using. So one of the really disturbing things here is to think about, in this country, the percentage of pregnancies that are unintended. And sorry about that, I hit the button the wrong way. And it's 42%. Now, what I have to tell you is if I was talking to you 10, 20 years ago, it would have been more than 50%. So this has improved. I also, full disclosure, not all unintended pregnancies are unwelcomed, because very often they are welcomed. But on the other hand, we do have a percentage of people conceiving who are not planning on conceiving, so they haven't had the benefit of preconception counseling and the like. What age group has the highest percentage of unintended pregnancies? And it's actually age 18 to 24 years. And not really all that surprising. And then if you get into some smaller subgroups, under 15 and over 40 are also times where pregnancy is typically unintended. And I think that's fairly self-explanatory. And by the way, what moved the needle from the greater than 50% down to 42% which that's a significant drop. Could be lower, but part of this is the enhanced use of long-acting reversible contraceptives. So one point to keep in mind, are we offering family planning services with every clinical encounter? I was somebody who had not done telehealth until COVID came around. And then, and I will say I was at the beginning saying to myself, well, let's see how much we actually can get done without having the patient in the exam room. And then I was thrilled to see what we could accomplish. And one part that I've always included in my practice, which has historically been about 60% primary care, about 40% same-day urgent care. I was always an advocate of offering contraceptive services at every single visit. I could be seeing a person capable of carrying a pregnancy for a sore throat, and a pretty episodic sick visit, and I'd ask about contraceptive needs above and beyond the person presenting for maybe HPV testing or STI screening or that type of thing. And would every person who could benefit from contraception identify as being female? No, not all of them will identify with being female. Gender non-binary or trans individuals. And I'll talk about contraceptive issues with the trans population a little towards the end of the program. And this is what I hear when I'm dealing with NP students or people in NP review. They'll say, but how do I even ask about contraceptive issues? Because very often, let's put it this way, there aren't a lot of RNs whose RN role included asking about contraception and having that be an important part of their clinical role. So very often it's this discomfort with asking about this. And this is a system called the one key question. And I can't praise this highly enough. You could go into the website. There's all sorts of learning materials there. And asking about contraceptive needs and providing support for those who desire pregnancy is incredibly important. So what's the one key question? Would you like to become pregnant in the next year? Easy. And you might say, well, yeah, but it's a closed-ended question. There is a response to that, yes or no. And I have found in practice, it's highly variable on that. There's a like, well, if I do get pregnant, that's okay. If I don't, that's okay. There are a million shades of gray that you might not think are there. And the one key question approach is patient-centered and focuses on equally supporting those who want to get pregnant, those who do not wish to get pregnant, and those who are ambivalent. And one key question addresses health equity, including perinatal equity and maternal child health. I suspect, given that we're all educators and knowing your commitment to excellence in teaching NPs, that you are probably familiar with this one sheet that comes from the CDC. It is available, open access. You can print it out black and white or in color. I find it very, very helpful as a talking point with patients. And as you could see, it goes from bottom to top, least to most effective contraceptive methods. And at the top there, I'm not going to talk about permanent sterilization. That goes beyond the scope of this presentation. But you'll see for the most effective with less than one pregnancy per 100 women in a year are the progestin-only implant and the IUDs. and there's both levonorgestrel and copper-containing IUDs. And I'll talk about all of these during the program. And what's one of the benefits of this, of course, is more or less set and forget that they're great. They provide contraceptives backup for long periods of time once they're inserted. But did you notice I said the words once they're inserted, right? So it involves a procedure, and the cost of these is generally such that many practices will not just stock them on the shelf and say, oh yeah, you're here today, I'm going to be able to put an implant in or an IUD. Very often the insurance needs to be billed, the patient needs to come back. So the benefit is wonderful. The drawback often require at least one extra patient visit. Now, the next down, the reversible, where you've got 6 to 12 pregnancies per 100 women in a year, include injectables like Depo-Provera, the pill, and I'm going to talk about combined oral contraceptives as well as the progestin-only pill during the program. And whatever I think of is under the category of combined hormonal contraceptive, that would be pill, patch, and ring. So that will be products that contain both estrogen and a progestin. Diaphragm, not a bad option. It is a barrier method, and I'm focusing my comments here on hormonal methods. So when we look at this, and then the latter part, where 18 or more pregnancies per 100 women in a year, you could see there are some of the barrier methods there: withdrawal, fertility awareness, spermicide, and the use of the contraceptive sponge. And please note, with the contraceptive sponge, which creates a physical barrier to sperm entering the uterus, and it also has spermicide in it, please notice how much more effective the contraceptive sponge is for nulliparous women versus parous women. So it makes a big difference. Literally, it's twice as effective in a person who's never given birth versus a person who has given birth. Medical eligibility criteria categories. I find that NPs getting ready for boards are often absolutely perplexed by this, and they can't figure out what these medical eligibility criteria are. This is the recommendation from the CDC on who should use and not use certain contraceptive options. So MEC category 1, no restriction for the use of the contraceptive method. MEC category 2, advantages of using the method generally outweigh theoretical or proven risks. Most contraceptive forms in most healthy people seeking hormonal contraception are MEC 1, MEC 2. Now, MEC 3, theoretical or proven risks of the method usually outweigh the advantages, not recommended unless more appropriate methods are not available or acceptable. And then MEC 4 is pretty much saying, don't do it. We know there's an unacceptable health risk, and so what we want to do is avoid that. So let me give you a quick example on this. COC is combined oral contraceptive, again, estrogen, progestin containing, and the P means patch and the R means ring. So tobacco use, what do we know? It increases the risk of tobacco use has a myriad of problems with it. But overall, tobacco use combined with an estrogen progestin containing contraception increases the clot risk, okay? And that is because estrogen is prothrombotic, tobacco use is prothrombotic. However, in individuals under the age of 35, it's MEC category 2, which is at this point, you know that there's a potential increased thromboembolic event risk, but pregnancy is also more risky to people who smoke. But then when you get age 35 years and older, you can see lighter cigarette smoking, like less than 15 cigarettes a day, you get to category 3. 15 or more cigarettes a day, you get to category 4. And the way I practice, what I will say is, if I do see a patient who is using combined hormonal contraception, whether pill, patch, or ring, once they start to get into their 30s, I start talking to them about the fact that I will no longer renew these medicines once they hit around age 35. And quite frankly, I'm not all that happy about it, even under age 35, because what that obviously says is the person is 34 years, 364 days old. It's okay for them to take the pill, patch, or ring. And the day they wake up when they're 35, all of a sudden they shouldn't be using it. That doesn't make any sense. And why do we not see that risk noted on heavy smoking with younger women under the age of 35? The reality is we all have higher clot risk the older we get. And I know 35 is very, very, very young, very young. So you might say, okay, well, they're kind of stuck between a rock and a hard place for hormonal contraception. Look at everything else, though. Progestin is not prothrombotic. And the progestin only pill that I find by many providers has been relegated to the hormonal contraception that is used during lactation is actually one of the best contraceptive options around for a person with a chronic health problem. And I'll get into that in a little bit later. DMPA is Depo-Provera, the progestin implants. And then, of course, the IUDs would be category 1, because unless there's some other reason for this, smoking alone, there's not going to be any more prothrombotic activity with an IUD, whether it's copper containing or levonorgestrel containing. So what is the most common form of contraception used in the United States? The most common is actually combined hormonal contraception, including low-dose estrogen in the form of estradiol, and then a progestin. And of course, as I said, the pill, patch, or ring. I've given you a couple of trade names there on those. So what's in combined hormonal contraception? The progestin in the estrogen parts work synergistically to inhibit ovarian and pituitary, to inhibit the stimulation of the gonads by the pituitary hormones, and therefore there is not ovulation. Okay, so it's ovarian and pituitary inhibition. Interestingly, most of the contraceptive benefits of a combined hormonal contraception actually comes from the progestin part, not from the estrogen part. Because the progestin part, the cervical mucus thickens, that adds a physical barrier to sperm entering the uterus. The endometrium becomes very, very, very thin. A nice, rich endometrium is not there to support a fertilized egg if one gets fertilized, and progestins only can also provide some cycle control. Now, interestingly, with estrogen, there's thinning of and increasing the cervical mucus. So progestin thickens, estrogen thins, and the endometrial proliferation is seen with the estrogen side. So why the heck is the estrogen even there? Part of the reason the estrogen is there is to afford, if the person taking the pill, patch, or ring wants to afford them the opportunity to have a menstrual-like flow or a shed of the endometrial lining with withdrawal of the CHC. That's why it's there. The very, very earliest birth control pills, when they were in clinical trials, this was the early 1960s, were high dose progestin only. And what I want you to remember back then, women couldn't just walk to your neighborhood pharmacy and buy a pregnancy test or order one online. They couldn't. Pregnancy tests were expensive. They involved going to specialized care for them. It was a difficult situation. And the initial feedback from to the researchers for the women who were taking the early birth control pills were, if we don't get our period, how can we tell we're not pregnant? Because that's what they were into. Their reassurance that they weren't pregnant was by getting their period. So progestin only, they had the thinning of the endometrium, no withdrawal bleeding, okay? And they weren't having periods. So the estrogen was added in many, many, many years ago, mostly to counteract the amenorrhea that would go along with being particularly on a high dose progestin pill. So this gives you an idea, again, of some of the combined hormonal contraceptive products that are around, and both the pill, patch, and ring form. Progestin only products, a number of those as well. Now, I do want to give O-pill, the Norgestrel product that is available OTC, as just a wonderful, wonderful opportunity for people who are capable of carrying a pregnancy to be able to access hormonal contraception without a provider visit. So if you go like, not so sure how I feel about that, not so sure about that, I'll give you a little bit more information about using progestin only pills. Hopefully that will kind of sway you into team progestin only pill, which I am a big member of. And then you can see the implant, and then the Depo-Provera injections as well. Okay, so what's the major risk with combined hormonal contraception use? It is the clot risk. Now, there can be other adverse effects, not that I want to minimize those, like some breast tenderness, maybe mild nausea when the person first goes on them. Generally, the breast tenderness and the mild nausea can be ameliorated by using a really low dose estrogen form, because those are usually estrogen adverse effects. But I'm going to focus in on what keeps us awake at night, and that would be the clot risk. And what is it calculated against, that risk? And this is the question the student says: how can I prescribe a med that I know could cause harm? You know, I read the prescribing information, and it talks about the thromboembolic risk with these. So what is the thromboembolic risk of a younger woman, reproductive age, not taking any hormonal contraception? Nothing, okay? It's about 1 in 12,500. It appears as if that risk is not changed with progestin only use, okay? Again, because you took the estrogen out, that's the prothrombotic part. Likely doubled with combined hormonal contraceptive use, but it's dependent on a myriad of factors. But what I want you to remember is the risk of thromboembolic event during pregnancy is 4 to 5-fold increased from age match control baseline. So pregnancy very significantly increases thromboembolic risk, very significantly, by 4 to 5-fold. The birth control pill, patch, or ring likely doubles it. So in other words, pregnancy is riskier, and at the end of the pregnancy, guess what there is? There is a baby. And that might be, as I mentioned before, a welcomed child, and it might be a very challenging situation. So how can healthcare providers help with hormonal contraceptive success? And you want to remove barriers to method start. Barriers are particularly a deterrent to teens and adults under the age of 24. So we've got a case study here. And as I've said with all the other programs that I've done, you are more than welcome to use these case studies with your students. We're here, I'm here to help you folks out. So it is a 16-year-old gravidas-0, para-0, AB0 young woman, sexually active with a male partner for 4 months, currently using condoms, but wants a more reliable method. She states that she doesn't want to put anything into me. And it's not that uncommon to hear that from younger women. They don't want an implant, they don't want an IUD, and has heard about birth control pills and asked for a prescription. She denies a history of a venous thrombotic event. She's a non-smoker. She's generally healthy. Her LMP ended about 4 days ago, normal limit timing and flow. Her boyfriend lives in another state, and she's not seen him since the LMP began, nor has had heterosexual intercourse with another partner in the interval. So MEC category, from what we know here, we'll take a look at this. She wants birth control pills. What does she need for clinical evaluation today? Should you order a pregnancy test before she goes on the pill? And when can she start her combined oral contraceptive patch or ring? So let's take a look at this. She's under the age of 40. She doesn't smoke. So she's category 1 for MEC, for pill, patch, or ring. And again, when you look across here, you'll notice for progestin only pill, all ages, she's category 1, implant, all ages, MEC category 1 by age. I'm doing age specifically as the criteria. Injection under the age of 18, it is, so that would be Depo-Provera. It is category 2. And the reason for that is that there is concern about bone mass density with this. And IUDs sometimes are classified as category 2 for this age group or under the age of 20. So what about the recommended examinations and testing prior to initiation of effective contraceptive? So this is a young woman who very bravely has come in and said, hey, I don't want to get pregnant. I really don't want to get pregnant. And remember, unnecessary tests can be a barrier to starting effective contraception. Women, particularly adolescents, are not comfortable with pelvic exams. They might think that they have to have a pelvic exam to start on any contraception, and they avoid seeking contraception due to this. And the other part is coming back for a second or more visit for test results can be problematic. So what is it that MEC says about exams and tests prior to initiation of hormonal contraception? And they say category A, essential and mandatory. Category B, contributes substantially to safe and effective practice, but implementation may be considered within the public health and or service context. Category C does not contribute substantially to safe and effective use of the contraceptive method. So this is a super busy slide. I know, might be a little hard to look at if you've printed out the handout. But what I want to point out to you is, remember, they said A is, yep, you better do this. So this is a young woman asking for combined hormonal contraception. What is the only thing that is category A? Check her blood pressure. That's it. Now, what are other category A's for diaphragm or cervical cap? Yes, you have to do a pelvic exam. And the same thing with the IUDs, and that's to rule in, rule out STIs, right? And the rest of these are CCCCC. So that says you don't need to bother doing this. You don't. You might want to do some of these as part of ongoing healthcare, but don't withhold hormonal contraception because of these other tests like glucose, lipids, hepatic enzymes, PAP, HPV testing, whatever it would be. So when can she start using the combined hormonal contraception? Can she start today? Remember, her period ended 4 days ago. Should she wait until the first day of her next period? Something else? Do you have any additional advice for her? So there are pretty much 4 different ways to start on birth control pills. One is the standard method, and this is the old school method. When they first came to market many, many, many years ago, this was the thought. Sunday start, you wait, and then start your birth control pill, patch, or ring on the Sunday after the menses began. Now, you'll notice she just wrapped up her period. That might be a couple of weeks from now. And there is an egg sitting, getting ready to ovulate. And so there's a risk of pregnancy. And what was the whole idea behind the Sunday start? That if you start the pill, patch, or ring on a Sunday, you won't get your period over a weekend. That was the whole idea behind this. We're going to leave it right there. And if she was to do that, she should use backup for 7 days. And I would advise her to abstain until she gets her next period. First day of menses start, you start the COC patch or ring on the first day of the menses. No backup is needed. No backup. Quick start. Ascertain the patient is not pregnant by history and timing of the menses. Likely pregnancy test is not needed. The idea behind this is trust what she has said to you. She said, I haven't been with my boyfriend or anyone else since I got my last period. And her period was normal limit time, normal limit flow. And then start the the combined hormonal contraception the day you see her, and use backup or abstain for 7 days. Now, Jumpstart, I prescribe Jumpstart fairly if there's been unprotected intercourse since LMP. I'll talk about emergency contraception towards the later part of the program. Prescribe oral hormonal contraception. Start the COC, the patch, the ring that day. Use backup or abstain for 7 days. In other words, these last two break down the barrier of waiting. She's in your office. You know what it's like with patients. You want to capture the moment, and hopefully she is and provide her with what she has asked to get. And this is perfectly reasonable. She wants birth control pills. So now this was a pretty easy case, younger woman, healthy. I would say the key teaching point here is when can she start on something, and does she need a pregnancy test? But what do we know? That there are a lot of individuals who would be benefit from combined hormonal contraception who have chronic health problems. So let's take a look at this. So we have a 22-year-old who smokes 1 pack of cigarettes per day. She's younger. She has no additional comorbidity. By MEC category, she's category 2. Would you write her a birth control pill prescription or patch or ring? And the answer is yes, because her risk of clot with smoking and CHC is less than her risk of clotting during pregnancy. 29-year-old with PID currently has PID. Well, that is an issue with an IUD only, but for COC or CHC, it's category 1, no restriction. So obviously a yes. 45-year-old with recurrent tension type headaches. So with non-migrainous headache, it's category 1 if age 40 or below, category 2 if above age 40. So that would be okay. One thing to keep in mind with recurrent tension type headaches, shut the period off by using CHC without withdrawal. Very often that helps tremendously in headache control. A 25-year-old with migraine without aura, including menstrual migraine, where menstrual suppression is an option, category 2, but migraine with aura, it hops up to category 4. So category 2, I wouldn't hesitate to prescribe, but category 4, no, because of that. So in female birth gender assignment with migraines with aura, they have what increased risk for stroke compared to women without migraines. Now, this is aside from contraception, okay? They have about twice the risk of stroke as women without migraine. Now, that risk is quite low, but it's stroke. This isn't like a little upset stomach or something like that. It's stroke. And that risk is nearly how many more times if you add combined hormonal contraception? It goes up 6-fold. Again, it's still not that common, but one more time, it is stroke. So what about migraine with aura and combined hormonal contraception? What other options can you offer them? Could it be a copper-containing IUD? Yes. A levonorgestrel containing IUD? Yes. Progestin-only pill? Yes. And please remember, like back to our 16-year-old patient, if she had migraine with aura, she wants something today for effective contraception, and she's willing to have an IUD inserted. Progestin-only pill, brilliant for a gap contraceptive measure. I just can't say it strongly enough. Wonderful. Depo-Provera, yes. Progestin-only implant, yes. All of these are category 1 for migraine with aura. Now, I put like a little star next to the Depo-Provera because sometimes headaches will worsen with that. And one of the challenging parts of that is once the shot's in, it's there for a number of months. And what you will find is that if it's giving them more headaches, they're just going to have to kind of wait it out till it's out of the body. 36-year-old woman with primary hypertension who's taking an ARB and hydrochlorothiazide. What do we know about ACE inhibitors and ARBs? When a pregnancy is exposed to them, they can cause profound fetal hypotension. So if there's hypertension with adequate control, it's still category 3. Risks usually outweigh the advantages. Hypertension with poor control, category 4, unacceptable risk. So what about though, let's mix this up. You've got a woman with well-controlled hypertension who is on a known teratogenic drug. She would prefer the ARB, cross out ARB, right? ACE inhibitor, same difference, and hydrochlorothiazide. So here's something that you want to keep in mind. If she's on progestin-only pill, or you can offer her this, with good high blood pressure control, it's category 1. Why? You got rid of the estrogen. There went the prothrombotic risk. Now, let's say her blood pressure control is not great. It's category 2. But one more time, progestin-only pill, while working with this person to improve blood pressure control, get the appropriate consult if this individual wants to conceive, or help gap them over to a long-acting reversible contraceptive form with a chronic health problems like this. So true or false with hypertension and POP versus CHC use, true or false? The impact on blood pressure with POP, progestin-only pill, is observed to be negligible. And that's true. The average rise in blood pressure with combined hormonal contraception is approximately 5 millimeters of mercury systolic and 3 millimeters of mercury diastolic. That's also true. So you have a 19-year-old whose BP is 102/70. That little rise in those two numbers meant nothing. But if you've got an adult with poorly controlled hypertension, you could see that that could be clinically significant. So what about birth control pills and progestin-only pills in antimicrobial use? So based on evidence, but not popular belief, what's the correct answer to this one? The use of which of the following antibiotics is most likely to reduce combined hormonal contraceptive use, pill, patch, or ring, or progestin-only pills effectiveness? Is it A, amoxicillin, B, ciprofloxacin, C, doxycycline, D, rifampin? And the correct answer here is rifampin is the only one of these that will reduce the birth control pill, patch, or rings effectiveness. Same with POP. So what happens when a person goes on an antibiotic when they're on particularly birth control pills? Because now we're dealing all with the gut. What do we know? What's one of the most common adverse effects of going on an antibiotic? Loose stools. Okay. Why loose stools? Because what ends up happening is the normal gut flora is reduced, and so the stools get looser. Well, one of the things that we know is with an alteration of bowel flora, there is interruption in enterohepatic recirculation of the hormones found within birth control pills, reduces circulating hormone levels, increase spotting, but it does not look like it reduces contraceptive effect. Okay. And this has been known for a while. Anti-infectants that do not reduce the effectiveness of oral contraceptives, tetracyclines, including doxy, ampicillin, amoxicillin, metronidazole, brand name Flagyl, and the fluoroquinolone antibiotics like levofloxacin and moxifloxacin. So what's the deal with rifampin? Well, first of all, rifampin, you might go through your entire career and never need to prescribe a dose of rifampin. It has very, very, very narrow indications and a handful of infections. But it is an enzymatic inducer. It's a cytochrome P453A4 inducer, and it makes then the estrogen and the progestin get offloaded. General rule, what will happen is if the person's continuing to use the CHC, or I should also add the POP as advised, all of a sudden they're spotting. They're spotting. But if you have a person using hormonal contraception who does not desire pregnancy, what advice should we give them? Continue to take the hormonal contraception, even if spotting occurs. Use a backup contraceptive method for the duration of time, taking the interacting med plus an additional 7 days. But for antimicrobials, one more time, it's rifampin only. Hold on, I'm in a hotel and somebody's knocking on my door. I apologize. Yes. Okay, person's gone. All right. What about select long-acting reversible contraceptive methods? So this would include copper-containing IUDs and levonorgestrel-containing IUDs. How do these work? The precise mechanism of contraceptive action for these devices is not fully understood. Neither device appears capable of interrupting an implanted pregnancy. The copper the copper part of it can provide a sterile inflammation. Actually, both of these can cause a sterile inflammation within the uterus that is toxic to sperm and ova and impairs fertilization. The copper is kind of like a little bit more boosted than the levonorgestrel on the inflammation part. But what the levonorgestrel does is it gives a thinned endometrial lining that will not support a fertilized egg. Okay. And so when we think about this, is that in addition to the thin endometrial lining, the levonorgestrel containing IUD causes local uterine changes by the presence of progestin that also thickens cervical mucus, resulting in a physical barrier to the sperm from entering the uterus. And that's one of the reasons why we often notice that women who have a levonorgestrel containing IUD after a number of months have scanty, infrequent menses or they're amenorrheic. Copper-containing IUD, we know at minimum, once it's in place, 10 years, okay? But likely effective for up to 20 years. And that the levonorgestrel IUD, it depends on the IUD. They have different durations of use, up to 8 years. And all of these, to be perfectly honest with you, probably work longer than the FDA indication for them. So who is a candidate? Category 1 or 2 for a copper-containing IUD or levonorgestrel-containing IUD. A 25-year-old nulliparous woman, so she's never carried a pregnancy. She's category 2. Is it okay to insert the IUD? Absolutely. And a 33-year-old who smokes 2 packs of cigarettes a day. Well, first of all, suffice to say, we're going to have a little chat about the smoking, but wonderful option for a person with a really harmful habit like smoking, because you're not going to use a combined hormonal contraception as she gets older like this. So that's another yes. 25-year-old with a seizure disorder. Lots of seizure meds interact with combined hormonal contraception. So an IUD is a wonderful option. A 33-year-old woman living with HIV who's on antiretroviral therapy, absolutely. And then when we look at this, a 32-year-old with a known thrombotic mutation, so has something like prothrombin gene mutation or maybe factor V Leiden mutation that we know increases the risk of clot. For the copper-containing IUD, it's a number category 1. The levonorgestrel is category 2. So in other words, benefit does outweigh the risk on this. So what about PID? That's the big thing that folks get concerned about, and rightfully so, with IUD use. Some of the data that you will hear, or some of the reports that you'll hear from providers who have been around for a number of years, they'll talk some of the older IUDs and how much and in the way of problem there was with PID, with IUD use. The newer IUDs, and I use that term newer very loosely, like 10 plus years, not 40, 50 years ago. The risk of PID is much less. And this is one thing, a quote from the 2022 CDC STI treatment guidelines. The risk of PID associated with IUD use is primarily confined to the first 3 weeks after insertion. If an IUD user receives a diagnosis of PID, the IUD does not need to be removed. That is, I'm not going to say it's a brand new recommendation, but it is newer. Years back, we always took the IUD out. However, a woman should receive treatment according to the STI recommendations and should have close clinical follow-up. If no clinical improvement occurs within 48 to 72 hours of initiating treatment, providers should consider removing the IUD. So, quick way of looking at this, IUD in place, presents on Monday with PID. Would be great to have follow-up with that patient on maybe Wednesday or Thursday as they've been treated to ensure that they're actually getting better. And if they're not getting better and they've been adherent to antimicrobial therapy, you could consider removing the IUD, but it's not mandatory. So what about emergency contraception? Well, why is there a need? Because after a single heterosexual coital act with no contraception, there is a 7.2% possibility that the woman will become pregnant. Emergency contraception helps to reduce pregnancy risk. And who are the candidates for this? Anytime unprotected heterosexual intercourse occurs due to potential method failure, like late for pills, missed pills, delayed Depo-Provera, dislodged or misplaced diaphragm, condom break or slippage, expelled IUD, and others, please make sure anyone who has been sexually assaulted and capable of pregnancy is offered emergency contraception, or of course, simply no contraceptive use. So what are the options? An IUD, a copper-containing IUD, can be inserted for emergency contraception. And then there are two oral agents, ulipristal, in a single dose of 30 milligrams. That's trade name Ella, and it's small e, like the woman's name Ella, but it's small e. And then levonorgestrel in an oral form, 1 to 2 doses. Usually it's just done one dose. The levonorgestrel is also available in most places over the counter, or you can buy it online. You know, it's not there. The barrier for obtaining levonorgestrel PO for emergency contraception, worse than it used to be, but it is not an impossible barrier. So emergency contraception users, pregnancy rate among emergency IUD users is 0.09%. That's actually the best out of all the EC options. But what did I say earlier? It means some kind of a special procedure, the IUD insertion, which I don't want to make it sound like that's terrible, but it is a procedure, and the cost of the IUD is high. Now, one of the benefits is once it's in place, it can provide ongoing contraception. And then the ulipristal and the levonorgestrel emergency contraceptive pills, equal effectiveness when taken within 3 days of unprotected intercourse. However, the ulipristal has shown to be more effective than levonorgestrel between days 3 to 5 after unprotected intercourse. So the question that always comes up with these hormonally based contraceptive options for EC is, how do they work? So levonorgestrel, which is a progestin, how does it work to prevent pregnancy? It really depends on when it was taken during the menstrual cycle. It likely interferes with fertilization. And I always feel like a 5th grade science teacher saying this. So fertilization, it prevents the egg and the sperm from meeting. And that's how it works. It inhibits or delays ovulation. That's its most likely effect. When taken 2 days prior to the luteinizing hormone surge, the levonorgestrel delays or inhibits ovulation. Once LH surge has occurred, the levonorgestrel has no impact on ovulation, but what it does is it inhibits tubal transport of egg or sperm. In other words, the tube isn't helping the egg and the sperm to meet one another. It slows down that tubal transport. Unlikely mechanism, it doesn't look like emergency contraception with levonorgestrel results in or let me put it another way. Emergency hormonal contraception with levonorgestrel results in minimal to no alteration in the endometrium, therefore unlikely to inhibit implantation of a fertilized egg. Now, Ella, or ulipristal, it's a receptor modulator, and it acts as a progesterone agonist antagonist, therefore directly inhibiting the effect on the follicular development and ovum release. And the changes in the endometrium, decreased thickness, can possibly alter the likelihood of a fertilized egg being implanted. That's more theoretical than it is actual in action. And in contrast with levonorgestrel, as I said, it will work more that day 3 to 5 when compared to the levonorgestrel, and given prior to the LH surge, inhibits 100% of follicle rupture. So again, there's no egg. How is this taken? The Ella, the ulipristal, is it's a 1-dose tablet. When it's taken in the mid follicular phase, it causes inhibition of follicular genesis and reduction of estradiol concentration. Taken at the time of the LH peak, it will delay follicle rupture by 5 to 9 days. So the egg will probably still rupture, but the sperm is no longer viable. Taken in the early luteal phase, it decreases endometrial. When you look at this, ulipristal versus levonorgestrel, they both have their place. Levonorgestrel is available. Ulipristal is prescription only, so would require a provider visit. What about instructions for use with ulipristal? Take 1 tablet as soon as possible, with or without food, within 120 hours or 5 days of unprotected intercourse, or if known or suspected contraceptive failure. If vomiting occurs within 3 hours of the dose, which by the way is quite uncommon, consideration should be given for repeating the dose. Emergency contraception using a copper-containing IUD, exactly what I said earlier that the IUD will do. Advantage, as I said, it can be left in place for 10 years for highly reliable contraception. Its one contraindication is an active uterine infection. Now, here is something to keep in mind, is that with hormonal contraception, for emergency contraception, with levonorgestrel, if the BMI is greater than 27, it looks like it's less effective. With ulipristal, it's when the BMI is greater than 35. So that is something we need to keep in mind, and not noted with EC use with the insertion of a copper-containing IUD in obesity. So with emergency contraception use, yes or no? Will an established pregnancy be interrupted? No. Is there a higher rate of birth defect if pregnancy does occur? No. All right. One last comment, and then I could see a couple of questions have come in. I'll be happy to take those. What about contraceptive options for transgender and gender diverse individuals? This is a comment from ACOG. Gender affirming hormone therapy is not effective contraception. So if you have a trans male, so female to male transition, and they're on androgen and things along those lines, probably, not always, but probably their menses has ceased, but do not trust that that is going to be adequate to prevent pregnancy. Sexually active individuals with retained gonads who do not wish to become pregnant or cause pregnancy in others. So obviously we're talking about trans in female or male, and others should be counseled about the possibility of pregnancy if they have sexual activity that involves sperm in oocytes. So this is actually a really good source of information on healthcare for transgender and gender diverse individuals. So please keep those folks in mind. So in conclusion, there is a lot to share with our students. It's always interesting. And I'd be happy to take your questions, and thank you so much for your time and attention. Okay, so question came in, does a 6-fold increase of stroke for adolescents with migraine with aura as well? It does get more. A 40-year-old with migraine with aura is much higher risk than like a 16-year-old with migraine with aura. But the question here is, had a 16-year-old recently on COC with severe migraines with aura, including multiple trips to the ED for abortive management. Migraines are also associated with the menses. PCP had prescribed COC, which seemed concerning with the migraine with aura history and the severe symptoms. I agree with you on that. I do. And what we're dealing with here is, all right, we've got a teen. I'm going to assume there is a need for contraception. Good choice for hormonal. Well, first of all, if I was seeing this patient myself what I would talk to this person about is considering a levonorgestrel containing IUD. Because here's the thing, the progestins aren't going to increase clot risk, but they could increase headache risk, okay? And so I would, as a gap to get over to a long-acting reversible contraceptive method like the IUD, I would, without hesitation, prescribe progestin-only pills. It's a pretty mild dose, if you will. I know that's highly scientific to call a dose of a drug mild, but it's not super high, and I would do them as you typically do without withdrawal. And the other thing, this child is in desperate need of getting on migraine prevention therapy, because running in and out of the ER, suffering like this, it is just not good. So whatever the most appropriate migraine prevention medicine for this young adult would be what I would advocate for. I personally would not feel at all comfortable with putting somebody like this on a combined hormonal contraception. Okay. So there was actually only one question. What I'll do here, I want to thank you for your time and attention. We have Nurse Practitioner Week coming up shortly. I want to thank you so very much as one nurse practitioner to another. I want to thank you for your time and attention, and just, you know, you folks are shaping the next generation of nurse practitioners, and it is a tremendous responsibility, but also a wonderful gift. So thank you for doing that. I'll wait 1 or 2 more minutes and see if any more questions come in. And if anybody put a question in the chat, if you could cut it, paste it out of the chat and put it in the QA, I'd appreciate it. I usually don't take a look at the chat, because more what that tends to be is more customer service issues. Okay, no more questions have come in. One more time, thank you for your time and attention, and thanks for all you do to promote our profession. Good night.